Hi everybody and welcome to our module on beta-lactam antibiotics. Shown on the screen is the chemical structure of penicillin. I don't recommend you memorize this. I'm showing it to you now so you can understand what makes penicillin different from other beta-lactam antibiotics. So penicillin has this structure in the center of the molecule called a beta-lactam ring. It also has a ring next to it called a thiazolidine ring. So penicillins were one of the first antibiotics discovered, but over time bacteria began to become resistant. So organic chemists began modifying this structure to try and maintain the bacterial effect of the drug, but trying to get around the resistance of the bacteria. And the way they did this was by keeping the beta-lactam ring, but modifying the side structure here. So we'll talk about in this module a number of antibiotics which still have a beta-lactam ring just like penicillin, but they have different structures attached to that beta-lactam ring. And the three groups of antibiotics that are beta-lactams but are not penicillins are the carbapenems, aztreonam, and the cephalosporins. All of the beta-lactam antibiotics have a similar mechanism of action to penicillin, and I discussed this mechanism in detail in the video on penicillin antibiotics. But all of the other beta-lactams, just like penicillin, bind to transpeptidases, which are also called penicillin binding proteins or PBPs. They prevent the cross-linking of peptidoglycan. This leads to autolysis of bacterial cells, and therefore all the beta-lactam antibiotics are usually bactericidal. In addition, because all of these antibiotics possess a beta-lactam ring, they are potentially susceptible to beta-lactamase enzymes, although as we will see, many of them are specifically designed to resist beta-lactamase degradation. Our first group of beta-lactam antibiotics are the carbapenems. Drugs in this class include imipenem, meropenem, ertapenem, and doripenem. The carbapenems are beta-lactam antibiotics, but they are not penicillins. If you look at the bottom of the screen, I've shown the chemical structure of imipenem. It contains a beta-lactam ring, therefore it is a beta-lactam antibiotic. However, this beta-lactam ring in imipenem is not attached to a thiazolidine ring. It is attached to another ring structure, but not a thiazolidine ring. Therefore, this is not a penicillin antibiotic. The major advantage of the carbapenem antibiotics over other beta-lactams, especially over the penicillins, is that the carbapenems are resistant to cleavage by most beta-lactamase enzymes. Let me pause here and mention extended spectrum beta-lactamase enzymes, or ESBL. These are plasmid-mediated bacterial enzymes that confer resistance to most beta-lactam antibiotics, including penicillins, cephalosporins, and aztreonam. These beta-lactamase enzymes are found only in gram-negative bacteria. They're often found in Pseudomonas and Klebsiella, but they can also be found in these other gram-negative bugs listed on the screen here. And once one of these bugs obtains one of these enzymes, it becomes very resistant to most beta-lactam antibiotics. Carbapenems are the drug of choice for ESBL bacteria. These drugs have a very broad spectrum, including coverage of bacteria that possess ESBL enzymes. They can cover most gram-positives, they can cover gram-negatives, including Pseudomonas and Enterobacter, and they can also cover anaerobes, including Bacteroides fragilis. For this reason, they're usually reserved for severe infections. They're often used in hospitalized patients, especially in cases where the blood cultures show that the bacteria causing infection is resistant to many beta-lactam antibiotics. Imipenem was the first commercially available carbapenem. However, it had a unique problem in that it was metabolized in the kidneys. This led to a loss of its antibacterial effect. It also led to production of nephrotoxic metabolites. The enzyme in the kidneys that metabolizes imipenem is called dihydropeptidase 1. So for this reason, imipenem was given with cilastatin, which was an inhibitor of dihydropeptidase 1, and that led to improved effects and less toxicity. Imipenem is the only carbapenem that has this issue. With the other drugs, you do not need to give them with cilastatin. Imipenem and meropenem are older carbapenems. There are no important differences in spectrum of activity or efficacy. Doripenem and ertapenem are the newer carbapenems. Doripenem is very similar to imipenem and meropenem. Ertapenem has some resistance in some ESBL bacteria. However, its advantage is that it has once daily dosing, but it does have weak activity against Pseudomonas and some other bacteria that have the ESBL enzymes. Common side effects of these drugs include GI side effects like nausea, vomiting, and diarrhea. Also, some patients develop a skin rash. Neurotoxicity can be seen, especially seizures. This occurs because these drugs have been shown to inhibit GABA receptors. Recall that GABA is an inhibitory neurotransmitter, so when GABA effects are blocked, you can have overactivity of neurons, and that can lead to seizures. This is especially a problem when high dosages are used or in the setting of renal failure. And of all the carbapenems, the lowest risk of seizures appears to be on patients taking meropenem. Our next beta-lactam antibiotic is aztreonam. Aztreonam is a monobactam. It gets this name because its chemical structure includes a beta-lactam ring not fused to another ring. In penicillins, the beta-lactam ring is fused to a thiazolidine ring. In cephalosporins, the beta-lactam ring is also fused to another ring. The same is true of carbapenems. In aztreonam, however, the beta-lactam ring sits all by itself, not fused to another ring. Therefore, it's called a monobactam. Aztreonam has a very specific mode of action. It binds to penicillin binding protein 3, which is found only in gram-negative bacteria. Once it binds, it has the usual effects of a beta-lactam antibiotic. It prevents cross-linking of peptidoglycan and leads to autolysis, and therefore it is bactericidal. It has limited susceptibility to beta-lactamase, although there is still some resistance among bacteria that possess the ESBLs. Because it binds to PBP3, which is found only in gram-negative bacteria, it is only active against gram-negative bacteria. It does not bind to the penicillin binding proteins of gram-positive bugs, and it has no activity against gram-positive bacteria or anaerobes. It is, however, active against most isolates of Pseudomonas. This drug is administered intravenously. It's usually reserved for serious infections among hospitalized patients. Two things to know about aztreonam. One is that it is synergistic with aminoglycosides, so when given together with aminoglycosides, the drugs have more activity than when either drug is given alone. In addition, there is no cross-reactivity in patients who are allergic to penicillin, so a key niche for this drug is among patients who have a severe life-threatening allergy to penicillin. You can use aztreonam safely in those cases. Our final class of beta-lactam antibiotics are the cephalosporins. They have a chemical structure that looks a lot like penicillin. However, they are not attached to a thiazolidine ring. They are attached to a ring with a different structure, and therefore they are not penicillin antibiotics, but they still have a beta-lactam ring, and therefore they are still beta-lactam antibiotics. The cephalosporins were brought to market in waves over several decades, and they are traditionally divided into the first generation cephalosporins through the fourth generation cephalosporins. The first generation drugs have mostly gram-positive coverage. The successive generations have increasing gram-negative coverage. The first generation cephalosporins include cefazolin and cephalexin. These drugs were developed at a time when Staph aureus was showing lots of resistance to penicillin. So if you know that, it's easy to remember that these antibiotics cover many gram-positives, including Staph aureus, although not MRSA. They are stable against the Staph aureus beta-lactamase. You can think of them as similar drugs to the anti-staphylococcal penicillins like dicloxacillin and nafacillin. They do not cover Enterococcus or Listeria, so they're not used for these gram-positive infections, and they are susceptible to most gram-negative beta-lactamases, so they're not used for gram-negative infections. So their main use, therefore, is in situations where you want to cover methicillin-sensitive Staph aureus. So that includes surgical wound skin infections, and in addition, cefazolin is often given pre-op for patients undergoing surgery to prevent skin infections after the operation. Second generation cephalosporins include cefuroxime, cefoxitin, and cefotetan. These drugs were designed to treat amoxicillin-resistant infections. So in the penicillin video, I talk about how amoxicillin has some activity against gram-negative bacteria. However, it is still susceptible to beta-lactamase enzymes just like the natural penicillins. These drugs were designed to overcome infections that are resistant to amoxicillin. Therefore, these drugs, compared to the first generation cephalosporins, have more affinity for gram-negative penicillin binding proteins. This makes them more effective against gram-negative bacteria, just like amoxicillin. However, unlike amoxicillin, these drugs have some resistance to beta-lactamases, therefore they can overcome many amoxicillin-resistant bacteria. Compared to the first-generation drugs, they have increased gram-negative bacteria. Specifically, they often cover H. influenza, Enterobacter, and Proteus. They also often cover E. coli, Klebsiella, Serratia, and Neisseria. They also show increased anaerobic coverage compared to the first-generation cephalosporins, including Bacteroides fragilis. Cefuroxime can be given orally. It's sometimes used to treat otitis media because it has good coverage of strep pneumonia and coverage of H. flu as well. It's also sometimes used for UTIs in children. In urinary tract infections, you want to cover E. coli, but in children, fluoroquinolones cannot be used. Cefoxitin and cefotetan are IV drugs. They are sometimes used in pelvic inflammatory disease because they cover Neisseria. They're usually given together with doxycycline to cover chlamydia. They're also sometimes used in children who have appendicitis prior to surgery. They will cover E. coli. They'll also cover gram-negatives and some anaerobes. They're usually given together with metronidazole, which is very good for covering anaerobes below the diaphragm. Third generation cephalosporins include ceftriaxone, cefotaxime, and ceftazidime. Compared to the second generation drugs, these drugs have broader gram-negative coverage. They have more resistance to beta-lactamase enzymes and more affinity for the gram-negative penicillin binding proteins. Ceftriaxone and cefotaxime are different from ceftazidime in that they do not cover Pseudomonas well. Ceftazidime's advantage among the other drugs in this class are that it covers Pseudomonas. Therefore, it's often reserved for hospitalized patients with serious gram-negative infections like sepsis or pneumonia. And most of the drugs in this class, especially ceftriaxone, can achieve good CSF penetration in the setting of meningitis. Therefore, especially ceftriaxone is often used for meningitis. A few details on ceftriaxone, because this is a drug you will commonly see used on your clinical rotations. It's commonly used to treat Neisseria infections. It's also commonly used to treat meningitis, as I said before. That's because it's active against strep pneumonia and also Neisseria meningitidis, and it achieves good CSF penetration in the setting of meningitis. There's one fourth-generation cephalosporin, that is cefepime. It has broad spectrum coverage, even more than the third-generation drugs. It can cover methicillin-sensitive Staph aureus, many gram-positives and many gram-negatives, including Pseudomonas. It is resistant to some ESBL enzymes, and this drug is generally reserved for hospitalized patients with serious gram-negative infections. Let me pause here and review the spectrum of beta-lactamase sensitivity among all the beta-lactam antibiotics. This is something that it is high yield for you to know for step 1 of your boards. Based on the side chain of the antibiotic, penicillins are the most sensitive to beta-lactamase degradation. The one exception is the anti-staphylococcal penicillins. These can resist only the staph penicillinase, but in general, penicillins are highly susceptible to beta-lactamase degradation. The cephalosporins display increasing resistance to beta-lactamase enzymes based on their generation. So the first generation cephalosporins are the most sensitive, followed by the second generation cephalosporins, third generation, and finally the fourth generation cephalosporins are the most resistant to beta-lactamase breakdown. Aztreonam is even more resistant to beta-lactamase degradation, although it's effective for gram-negatives only. And then finally, carbapenems are the drug of choice in the setting of ESBL bacteria. That's because they are highly resistant to beta-lactamase degradation. Our final cephalosporin drug is called ceftaroline. This is a very new drug. It's considered a fifth-generation cephalosporin, and its main niche is that it is active against MRSA. It was FDA approved in 2010. It's a prodrug converted to an active metabolite. It can bind to a very specific penicillin binding protein called PBP2A. This is a MRSA-specific penicillin binding protein that displays very low activity for most other beta-lactams, but it will bind to ceftaroline. For this reason, this drug can treat MRSA and also vancomycin-resistant Staph aureus, and that's its main role and the one that you want to remember for the Step 1 exam. It also covers some gram-negatives but not Pseudomonas, and it's been studied mostly in skin infections involving Staph aureus and also in pneumonia. Let's review the resistance mechanisms shown by bacteria that are resistant to the cephalosporins. Some bacteria will modify their penicillin binding proteins so that the proteins no longer recognize the drug. Some bacteria modify their cell permeability to the drug, and then, as we have been discussing, the cephalosporins display varying levels of beta-lactamase sensitivity. Let's review the adverse reactions seen among patients taking cephalosporins. Hypersensitivity or allergic reactions are common, and the same reactions that can occur with penicillin occur with cephalosporins. I discuss all of these in detail in the penicillin video. So patients taking cephalosporins, just like patients taking penicillins, can develop anaphylaxis, a maculopapular rash, serum sickness, hemolytic anemia, interstitial nephritis, or even the severe skin reactions, Stevens-Johnson syndrome, or toxic epidermal necrolysis. There is some cross-reactivity in terms of allergy with patients who are allergic to penicillins. So it was always taught when I was in medical school that if you were allergic to penicillins, you had a 10% chance of being allergic to a cephalosporin. Recent data have called this 10% number into question. It is probably lower. However, there is still some cross-reactivity, and this is an important issue when patients have a life-threatening adverse reaction like anaphylactic shock to a penicillin. You usually will not administer a cephalosporin due to the risk of cross-reactivity. Patients who take cephalosporins can potentially develop bleeding, so let's talk about why this happens. The first reason is because of a vitamin K deficiency. Vitamin K comes in two forms. The K1 form comes from your diet, it's found in green leafy vegetables, and the K2 form comes from your GI bacteria. Antibiotics reduce bacterial vitamin K production. In other words, they kill off many of the bacteria that produce vitamin K. The result is that the INR can potentially increase and potentially bleeding can occur. This is especially a problem for patients who are taking warfarin. They already have an elevated INR, and if you deplete their GI bacteria and their GI source of vitamin K, the INR can become markedly prolonged and bleeding can develop. Now this problem, vitamin K deficiency, can be caused by any antibiotic. Cephalosporins are not unique. You can also see this occur with any other class of antibiotics. Cephalosporins, however, have a second mechanism by which they can cause bleeding that is unique to this class of antibiotics. Cephalosporins can potentially lead to hypoprothrombonemia, which basically means reduced levels of clotting factors. This complication is associated with certain side chains found on some cephalosporins called N-methylthiotetrazole or NMTT side chains. This is an example of one found on cefotetan. Cefotetan has a side chain like this, so does cefazolin. These side chains can inhibit epoxide reductase. This is the same way that warfarin works. This leads to a decrease in hepatic synthesis of vitamin K dependent clotting factors, and it may prolong the PT-INR. It's reversible if you give the patient vitamin K, and most of the reports of this complication occur among malnourished patients who are already depleted in vitamin K and then are administered a cephalosporin with this type of side chain. If you want to read more about this rare complication, I've listed an article at the bottom of the screen. There is some evidence that cephalosporins can lead to nephrotoxicity when given together with aminoglycosides. Aminoglycosides are a well-known cause of nephrotoxicity, and these drugs are often given together with a cephalosporin. Some older reports suggested that the rates of nephrotoxicity among patients on aminoglycosides were higher when the aminoglycoside was combined with cephalosporin. Now, these data have been called into question, but nevertheless, you'll still read in many textbooks that cephalosporins can increase the risk of nephrotoxicity when given together with aminoglycosides. Our final adverse reaction is called a disulfiram reaction. This occurs when patients taking certain cephalosporins consume alcohol. They can develop warmth, flushing, and sweating, and this is the same reaction that occurs when patients drink when they're taking the drug disulfiram, hence the name. This results from inhibition of the enzyme acetaldehyde dehydrogenase, which is necessary for metabolism of ethanol. When patients on certain cephalosporins consume alcohol, this enzyme becomes inhibited by the cephalosporin drug. That leads to the accumulation of acetaldehyde, and that's what causes the symptoms of the reaction. This only occurs with some cephalosporins that have certain side chain structures. The ones that are commonly associated with it are written at the bottom of this slide. And finally, here's a slide from the biochemistry section showing the metabolism of ethanol in the liver. Ethanol is metabolized to acetaldehyde and then to acetate. The enzyme that catalyzes the final step is aldehyde dehydrogenase. This enzyme is inhibited by the drug disulfiram, which is given to alcoholics to discourage them from drinking. It's also inhibited by some cephalosporins, and that leads to the disulfiram reaction caused by high levels of acetaldehyde. And that concludes our module on beta lactams.